Okay, we are starting with substance-related disorders and finishing up with the nursing process. Assessment. Obviously, in assessment, we're doing a subjective and objective. The first subjective assessment that we should be doing is gathering information, asking questions about their history, their use, how much do they use, that sort of thing. In your book on page 351 under subjective data, they have quite a few questions down here that are important to know. I think it's important to make sure that we're asking how much do they use, how many drinks do they have per day, and not only how many drinks per day, but really trying to clarify that with how much alcohol. Do you drink a pint or about a quart? Because many times people will say they have one drink, but that one drink might be a huge glass or a huge amount, and they just minimize it by saying one or two drinks. Another thing that is important to ask, and that's down here in question number 4, is when was your last drink? And if you can remember what is the importance of asking that question, if you go back to your minor withdrawal and major withdrawal, that will help us to predict when they might start going into withdrawal symptoms. Okay, so all of those important questions to ask. It is important to also make sure that we're being non-judgmental. Many times patients are afraid of giving us accurate information because they're afraid that they're going to shock us, or that it's nobody has ever heard of a person drinking this much or doing that many drugs. So it's always better when we're asking questions to be non-judgmental, but when we ask them to overstate it so that they can tell us to, no, it's not that much, it's this much. So always make sure that you're prepared to, say quart, pint, or more, that sort of thing. Then next thing under subjective is the CAGE questionnaire, and that's on page 352. I do want you to know that the CAGE questionnaire can be used both subjectively and objectively, but it really gets into asking them some questions about more about feelings. Have you ever felt like you should cut down on your drinking? Have people ever been annoyed at you or criticized you for your drinking? Have you ever felt bad or guilty about drinking? Have you ever had a drink in the morning as an eye-opener to get rid of a hangover? Remember, that was one of the symptoms we talked about, is that when a person moves into the phase of chemical dependency, that many times they use just to feel normal. Okay, just to get them going for the day and feeling normal, to get rid of those withdrawal symptoms. So CAGE questionnaire, very important. Common defense mechanisms, I definitely want you to know those as well. On your outline, it talks about denial, projection, and rationalization. Denial is a huge one that we frequently see. We can say it as denial, where the person denies that they have a problem, and many times we see it as minimizing a problem. Well, I drink, but I rarely have more than one drink, or it rarely affects my work. So they're very much minimizing what's going on in their life because of the alcohol. Or I just have a few. All right, that very much minimizes. So minimizing or denying is a huge defense mechanism that we see. Projection is another one. Again, projection is pushing their problems onto others or blaming others for why they have a drinking problem or why they drink. For example, I drink because my boss is such a jerk, and that's the way I cope with it. Or I drink because my teacher is giving us 2 tests next week, whatever the case is. Projection, blaming it on your wife, etc. Rationalization is a form of rationalization is more like saying that there is a reason for it, and I have a very rational reason for my drinking, and that one of those might be, I know I have a problem, but I'm going to finish I'm going to quit drinking as soon as I get through this big project at work, or as soon as I, get through this tough time in my life. So there's always a reason, and they intellectualize it or rationalize it. Okay, motivation for treatment. We also need to be assessing for that. What is their motivation for treatment? Is it internal motivation? And that internal motivation would be that they're voluntarily seeking treatment. Internal motivation is always the best type of motivation, because those are the ones that are going to have the better chance of success. If they're internally motivated, if they are acknowledging that they have a problem and want to get it under control and improve. External motivation or coerced treatment is when family or friends or a doctor or a court of law is either coercing them or pushing them towards treatment, or by law they have to go to treatment. Okay, many times this is unsuccessful treatment, in the fact that many times people are very angry for having to be in treatment, very resentful about being in treatment, and because of that type of motivation, they have a lot of difficulty learning new ways to cope, acknowledging that they have a problem, and many times it is unsuccessful. The mental status exam is also subjective. Parts of it subjective that we need to have for our assessment. Okay, objective assessment. Questionnaires. Your book lists a bunch of questionnaires down there. I'm not going to have you required to know any of those except CAGE. CAGE, you will have to determine, the information that is subjective and more objective, but that would be one type of questionnaire that can be used. Physical findings. I want you to know the physical findings. For example, on page 353, it talks about signs and symptoms of liver cirrhosis. So as I said before, to know that purple box on page 353, signs and symptoms of liver cirrhosis, but also going back to page 329 and knowing those physical effects of chronic alcoholism as well. Lab tests. A lot of different lab tests that we can do. Of course, the BA is the blood alcohol concentration, and I want you to know that 0.1 is considered intoxication. THS is the marijuana. B's, and the third one there, benzodiazepines. Those can all be done through lab tests. Nursing diagnosis. I have a list of the nursing diagnoses on your outline. Those are the same ones that are in your book. I want you to be aware that that these all can be, and on your own, just from all the stuff that we've talked about before, be able to say, why would a person with substance abuse disorder have ineffective individual coping? Why would they have altered family process? And to go on down the line with that. Sensory perceptual alterations, that would be the hallucinations, and we know that individuals, depending on what substance they might be withdrawing from, can have hallucinations, can have that delirium, and so that's why they would have that nursing diagnosis. Outcomes. I have the outcomes that are listed down there, the three main ones, and then I've added a couple that are also important. Basically, these are things that we want them to be able to master, or things that we want to be able to see when they are done with treatment. They are able to cope in a healthy way and not choose unhealthy coping mechanisms such as drinking or drug abuse. We want them to make accurate or healthy decisions, impulse control, really be able to know what is our high-risk situations, how can I control my impulses. Okay, lifestyle changes, we'll talk about that a little bit later, but many of these individuals will have to make some major lifestyle changes, such as changing the friends that they hang around with, It might be that if they do live in a house with, say, their husband or wife, if their husband or wife does drink or do drugs, they are going to have to make some decisions about how supportive is the husband or the wife. Is the husband or wife willing to stop their use of those drugs or that alcohol? If they're not willing to do that, how are you going to cope with that? Other lifestyle changes might be, I need to change jobs if everybody at my job drinks or smokes or whatever the case is. It might be that I can't go out and hang out with friends right after work because it's always at the bars. And those lifestyle changes can be very, very difficult, and is probably one of the most difficult things to talk about and to change. And also improvement in work and family and social situations. Those are our outcomes. Okay, planning and interventions. It's important that we deal with the physical symptoms first. Okay, so we need to get them through the physical symptoms before we can start talking to them about coping mechanisms or 12 steps of AA or anything like that. We got to get them through the first with the physical symptoms. So we're going to talk about detoxing first. Okay, detox. Depending on the hospital the patient is admitted to, they can go through. Every hospital will have different programs. It may be that they have detox beds on their substance abuse unit. Might have 2 or 3 beds where they can be detoxed there, or they will do minor detoxification on their substance abuse units. Other hospitals will have all their detox patients go to the medical unit, regardless if they have a substance abuse unit or floor or not. So that will all depend. So detox, you have to know the signs and symptoms of minor and major withdrawal. There's no way that you can be able to provide good nursing care without knowing those minor and major withdrawal symptoms. We definitely have to monitor vital signs. We know that blood pressure, pulse, and respirations can go up in a person who's going through detox, and depending on how much they vary outside of normal limits will help us to determine how severe of a withdrawal they're going through. The prescribed meds that are pretty standard for anybody and going through detox is magnesium sulfate, and we talked about that already, and to know the reason for that, and thiamine, and we already talked about that as well, so know the reason for that as well. An environment that has decreased stimulation, we already talked a little bit about that, but a quiet room, plenty of opportunity to sleep and to rest, is important. We don't, if these individuals that are going through detox, if they are on the substance abuse unit, we do not require them to go to groups. We do not require them to have meals outside of their room. So it's very much, physical care until they get through that detox. Hallucination management. Again, not everybody who's going through detox is going to have hallucinations or go through more severe delirium, but we would all the same nursing communication, therapeutic communication that we would use for hallucinating patients, we would use here. And one of the key concepts, as you remember, is that we always need to focus on the feeling or the emotion that is behind the hallucination. I don't see spiders on the wall, but I'm sure that's frightening to think that you're seeing those, and then to bring them back to bring them back to reality, and to focus on the feeling behind that. Mental status exam, again, frequent checks with the mental status exam to make sure and again, a mental status exam is just a snapshot of how they are doing at that period of time, so they can change from within 5 minutes, within a half hour, so we need to be always looking at that mental status exam. Neurochecks as well, depending on, it's just a good routine to be doing neurochecks with these individuals who are going through detox. I&O, again, we said one of the major problems is dehydration, and we need to be monitoring that, and fluid volume deficit is a big nursing diagnosis. We need to monitor that I&O, ensure that they are getting enough fluids. It may be that we need to start an IV. These individuals may be on bed rest, and again, it might be strict bed rest, it might be a variation. They might need a sitter, they might not. They might, they might be able to follow instructions. Make sure before you get out of bed, make sure you call the nurse. You're not allowed to get out of bed. They may or may not be able to, follow those directions. You're going to have to make a decision about that. But again, if they are having, depending on their type of withdrawal that they might be having, minor, major, it may be very difficult for them to walk without stumbling. It might be that they are, unable to interpret stimulation that's coming at them, and so we need to really take care of that safety issue. Okay. Once a person gets through detox and it's determined that they are, the other thing with detoxification that I didn't mention but that we covered before is the need to give them benzodiazepines as a central nervous stimulant until they get through, and to prevent seizures and prevent major withdrawals until their body gets readjust. Those benzodiazepines, we did talk about those. Every hospital will have their own protocol and may use Ativan a lot. Some of them may use Librium or Valium. It just depends. Once a person does get through detox, they then will be moved into a new phase of the hospital treatment or the program treatment. And usually that next stage is intermediate care or rehab. Now, because a person has gone through detox, many times they will, depending on if they're a voluntary patient, will refuse to go further. They'll say, I'm detoxed, I can handle everything else on my own. This is the main thing that I wanted to do. Now I'm going to leave the hospital and I can take care of myself. And so just because somebody goes through detox does not necessarily mean that they are going to stay or will agree to stay to go through the rest of the program. And it is unfortunate if people just go to the detox because, again, depending on the person, they may not have the tools after detox to get out of the hospital and to remain sober. So the next, again, depending on the hospital, depending on the program, the next stage many times is intermediate care. And this is when a person is still in the inpatient hospital treatment that's still providing a very safe, structured environment for them. And they begin to deal with the issues of alcohol and drug addiction, trying to, what are those issues? How do they affect me? Accepting these issues and delving into those issues. Many times there are a variety of different programs. 30-day inpatient programs are common. Again, if your insurance pays for it, or if you don't have insurance, sometimes state funding will provide for 15-day inpatient program or variations on that. Private hospitals, and if you have your own money to pay for it, there are private hospitals like Hazelton and programs all over the country that will provide anywhere from 30 days to 6 months, inpatient programs. Rehab. This rehab would also be possibly could be considered part of that intermediate care, but rehab goes much further and continues longer than just the intermediate care. But these can be residential programs where a person actually stays overnight into 30 days, 3 months. Like I said, a private hospitalization might even be 6 months or a year. So there are residential programs. Sometimes there are outpatient programs. That one under residential program should say extended residential care. Again, that's kind of the same, but depending on your insurance determines as extended residential care, might be longer than 30 days. Outpatient care, again, depending on the program, a lot of different variations. Genesis used to have, when they, or Genesis does no longer have an inpatient substance abuse program, but they do provide outpatient care, and typically those are programs that last for 3 to 4 weeks, sometimes longer. They may be 4 hours of outpatient care or 8 hours, depending on the individual. They may work around the patient's schedule and say 4 hours in the morning before they go to the afternoon shift, or it might be 4 hours after work from 5 to 8 or 5 to 9. So there's a wide variation. Outpatient care would also include self-help groups and 12-step programs. The 12 steps of AA are the framework of a lot of these rehab programs. And we talked about this a little bit before, but AA is a very, very successful program for many, many people, and there has been a lot of research done on it that has shown that it is successful. However, there are many people who do not use AA and can be successful. Education is a major component in rehab, and is one of the big things that we see in a lot of the rehab programs is groups, but they're educational groups, where they might see a film that talks about the disease process, might talk and educate about coping mechanisms, might talk and educate about the anxiety, what to do with anxiety, how you cope with anxiety, those sorts of things. Client and family education. Enabling members, such as family members, we want to make sure that we are educating them as well, and bringing the whole family into treatment. As you remember, one of the things that you needed to review was the family roles in substance abuse families, and so the whole family. Many theories will say the whole family needs treatment, but client and family education is a huge part of any type of rehab or planning and interventions. But having family members really looking at clarifying the problems, looking at solutions or options that they might have, and how they can support that alcoholic or substance abuser and their family, and what they need, the family member needs for support. There's also family therapy, very, very important, and most inpatient residential programs have some sort of family therapy education groups that are built right into their programs. So the challenge is continuous self-reflection. Do I continue to be effective in my nursing interventions? Can I continue to offer hope to these people who are coming through treatment again? Can I communicate hope to them? Can I continue to communicate that they can do this if they work and they put the the pieces into practice? Because the saddest thing I think for me to see is to see nurses who are burnt out and treat patients very poorly when they come in for their third time or their fourth time, or write them off and basically are saying, communicating to them that you don't have any hope to get sober. Just keep that in the back of your mind. Okay, so relapse prevention. The big thing with relapse prevention, and they do a lot of education on this when the person is in the rehab portion. Okay, when they're in the residential treatments or outpatient treatments, they do a lot of this relapse prevention education. Really educating and encouraging people to look at what are my high-risk situations. When am I at a high risk for going back to alcohol or going back to drugs? Is it emotional situations with my wife? Is it stressful situations at work? Is it social situations where all my friends are out drinking, or I'm starting to get lonely at home because all my friends drink and I don't want to do that, and so then I start drinking by myself? What are those high-risk situations? And those individuals really need to start preparing for those high-risk situations while they are in rehab. And that's what a big part of that program is: building coping mechanisms, building support systems. And to really, talk about that relapse prevention is that we have to kind of view recovery as a lifelong participation, that we are in recovery. We're never cured. Okay, and that's one of the big things with AA. And when I talked about that kind of the cycle of addiction, that you are going to be in a lifelong participation in recovery. You can never be cured, and you can never go back to social using or experimentation, that sort of thing. Okay, now again, as I said, that's one theory, and not everybody follows that theory, but that theory, the recovery theory, has been proven successful. Another relapse prevention is having an AA sponsor. There's a lot of people that go to AA, but they don't necessarily have a sponsor. AA very much encourages and promotes that every individual who goes to AA, that they will be more successful if they have a sponsor, somebody that they get to know on a personal level, somebody that they can go out with and talk about problems, issues, a person that they can call at 12 o'clock at night and say, hey, I'm having these urges, or I'm just feeling really lonely, or I don't know what to do, that sort of thing. AA sponsors are people who have volunteered to be sponsors and have gone through some other training, but all AA sponsors are recovering substance abusers. General treatment approaches. I want you to read about these in your book, The Confronting Strategies. Education we talked a lot about, and referral and self-help groups we've talked about, and also lifestyle changes. I want you to read about that as well. Again, individuals are going to have to go through lifestyle changes to be successful and to anticipate those high-risk situations. It's very interesting working with substance abuse individuals, how often they and it's kind of part of their denial or some of their coping or some of their defense mechanisms, but how they believe, especially if it's their first time in treatment, how they believe they can go back to their same environment and not have any problems. Oh, I can go out with my friends. That's not going to be a problem for me. I know I'm going to be able to drink. Or my friends, they know that I have a problem, and they won't get on me for not drinking or whatever. So I can still go out to the bars and all that sort of thing. Or it might, so that again can be very difficult, and many times people are not willing to make those lifestyle changes until they've been in and out of the hospital 4 or 5 times, and they really see that they start to experience that lifestyle changes are huge. There are some people who realize they need to have those lifestyle changes and put some of those into place. I'm not going to hang around those friends anymore. But then they fail to make new friends, or fail to get involved in other organizations or other hobbies where they can meet new friends. And so they made a lifestyle change of not going out with old friends, but they start to become lonely and sad because they don't have any friends, or are sitting by themselves, and instead of making new support systems, they go back to their old lifestyle and get back right into the same problems that they had before. So I want you to read about that as well. And the only other thing is the evaluation, and basically we are evaluating our outcomes. Have they achieved those outcomes? And last slide I have here is the patient and alcohol detox. We basically covered all of this. Nursing care, I want you to know all that was discussed before, and then I also want you to know the action and use of antabuse and the action and use of naltrexone. And that is all, and we will see you guys on Thursday. Good luck studying.